Hello people, this is Dr. Muskaan this side, and today I'm going to discuss very interesting case. Let me start this case. Here is 50-year-old male who has came to ER with chief complaints of vomiting, hiccups since 15 days and fever since 1 day. On arrival, ABCS was done, airway was compromised on breathing assessment, respiratory rate was 24 per minute, SpO2 was 89% on 15-liter oxygen, NRBA mask, that is non-rebreathing mask. So desaturation था. On circulation assessment, pulse rate was 150 per minute, tachycardia, BP was 120 by 80 mmHg, sensorium was unresponsive, GCS was E1, V1, M1, that is 3 by 15. So what we have checked from ABCS कि airway compromise था, desaturation था, tachycardia था and sensorium was unresponsive. So HOPI, patient was apparently asymptomatic 15 days back. When he developed complaint of vomiting and hiccups, he received treatment at some hospital where he progressively developed weakness followed by respiratory distress and altered sensorium. He arrived to Sharda hospital with moderate grade fever that was 103 degree Fahrenheit, relieved on taking medications. Patient was intubated in the ER with the indications of low GCS, airway protection, sepsis and septic shock. There was difficult airway because of very poor oral hygiene and restricted mouth opening. After some time, this patient was shifted in ICU for further monitoring and management. Past history of the patient: his known case of hypertension plus old cerebrovascular accident history is also present, and there were no other comorbidities. Personal history: he is chronic smoker and chronic alcoholic. On examination, the acuities of the patient was not oriented to time, place and person. His GCS was 3 by 15. He was on mechanical ventilation, maintaining 88% SpO2 on AC/VC mode. Vitals of the patient when he was in the ICU was he was having hypotension. Why? Because his diastolic blood pressure was less than 60. Pulse rate was 71 per minute. Respiratory rate was 23 per minute. Tachypnea है थोड़ा सा. SpO2 was 88% and temperature was 98 degree Fahrenheit. Mechanical ventilation settings of the patient was: he was on AC/VC mode. FiO2 was 40%. Tidal volume was 4 to 5 ml. Respiratory rate was 24 per minute. IE ratio was 1:2, suggesting of obstructive lung disease. PEEP was 5. And further sepsis protocol, I have seen SIRs was present, that was hyperthermia, and second कभी patient hypotension में जा रहा था, कभी वो hypertension में जा रहा था. So 2 positive for SIRs. Sepsis was present because TLC count was 30,810. So 2 positive SIR plus infection suggest of sepsis. Further severe sepsis was also present. Why? Because sepsis है, hypertension है. Lactate level on the arrival was 4.8 millimole per liter, and there were signs of end organ damage also because of deranged CVC, LFT and KFT. Septic shock was also present because there was severe sepsis present, signs of end organ damage present, hypertension and lactate level was more than 4. Further, when I have seen the investigation picture of the patient was anemic, leukocytosis, increased urea, creatinine, uric acid suggestive of AKI, hypernatremia, hyperchloremia, serum transaminitis and hypoalbuminemia. ABG picture was normal to some extent. Urine out, but bicarbonate was less. Urine output, urine reports were showing 4 to 5. Urine reports were showing 4 to 5 pus cells in urine, and urobilivagin was positive. Further, malaria, dengue tests, HCV, HIV 1, 2, HBS were negative. CRP report shows 12 mg per dl, which was increased. Normal is less than 5. So CRP is acute phase reactant. Elevated level of CRP may be seen in inflammatory disorder, tissue injury, necrosis and infection. APTT level was 55.7 seconds, which is also increased. Normal APTT is 23 to 26. And what is APTT? APTT is activated partial thromboplastin time, which helps us in measuring how long it will take the blood to clot. It evaluates clotting factors. If its levels are high, it suggests bleeding disorder to liver disease. PTINR was normal. Prolactin was also increased. It was 4.07 nanogram per ml, normalized between less than 0.5, and it indicates sepsis, and it is also a biomarker which is specific for bacterial infection. Further, when I have seen the chest x-ray of this patient, it was chest x-ray, AP view, soft tissue bone linkage intact, overexposed film, expiratory film, and there were marked bronchovascular markings and left side pleural effusion. When I have seen the ECG of this patient, there were tall R waves in the lateral leads. In lead 1, AVL V5 V6 strain was also present, suggesting of LVH. Further, ultrasound picture shows small kidney size, small right kidney, minimal ascites, and when septic encephalopathy is present, uremic encephalopathy is present, hypoxic ischemic encephalopathy is present. It is also called as, the triad is called as metabolic encephalopathy, which I made the diagnosis. And when I've seen this patient on day 2, ABG was normal but a little hypoxic. Anion gap was also normal, but I was thinking कि अगर AKI है या यूरेमिया है तो पेशेंट का ABG नॉर्मल होने के बावजूद there is some metabolic hagma with metabolic alkalosis. Investigation picture was on little improvement side. Thrombocytopenia थोड़ा सा improve हो रहा था. 77,000 हो गए थे platelet counts. ल्यूकोसाइटोसिस भी कम हो गया था. पहले 30,000 था, अभी कुछ 29,000. And that's all. The interesting part in this case was learning ECG, LVH कैसे देखते हैं. Further, what is the indication of prolactin, CRP, APTT reports, and the triad of that metabolic encephalopathy, which gave a kick. And yeah, that's all. So I have enjoyed learning on this case. I hope you have also gained some good points listening to the history of the patient. That's all. Dr. Muskaan Bansal is signing off now.